situation and the lack of any logical reason why some of these people should be incarcerated will force that discussion to take place.
Let's move to another portion of the leaky bucket. Mr. Speaker, in Medicaid, do you think that managed care holds promise to reduce Medicaid expenditures and improve the care that's now being provided?
I don't think there's any question that managed care is going to be something that's going to continually, it's been debated for a long time. It's going to continue to be debated in both private insurance and private health situations and in the government situation as well. We started a task force Monday on managing Medicaid costs to try to look at and get to some of these answers. And it is a very challenging subject, believe me. It's so massive. We had to go around this last time, as most of you know, about the issue between a provider passport. We wanted to expand the program from the original counties that it now serves to try to see how far from these centers that it would constitute savings. We ran into a complete stone wall from the administration, and I use that term literally. They stonewalled us on giving us information because either they didn't know it or they didn't want us to know it, one or the other, and I think it's because they didn't want us to know it because I believe that the managed care approach and the passport approach does constitute a savings, but I think that there is an institutional pushback, Mr. President, from those in the government who don't want to actually recognize those savings. And some people will say, well, why do they do that? Well, because it's likely that if we save money there, we may have to use it somewhere else. One of the natural occurring phenomena in all of government is that these little bureaucracies, these departments, want to keep their budgets intact because if they do, there's no incentive for them to be to save money. There's no incentive for them to be efficient. If they're efficient, then we have a tendency to, as you would in your business, to take money from here if it's needed over here. And so, you know, there's a lot of problems that we have to overcome as far as that goes. But I think that you know, once we start understanding more and more and more and more and more of exactly how this budget works and how this program works, and that's what we're attempting to do, is really get down beyond the level that we're at now and find out, you know, why some of these comparisons. It's a huge amount of money, and it's you know, you can take the statistics and make it look about any way you want it to look if you've got command of the statistics. What we have to figure out, and we've never, as far as I know, in the General Assembly, gone this deep into the program, Mr. President, is figure out, you know, who's telling the truth, where the savings are, you know, what's actually comparing apples to apples, and get to the real bottom of the whole thing.
And just to clarify, you do and did disagree with the administration on what there is evidence that passport in Louisville, the managed care program,
I do and did and continue to do.
And Senator, if you would, before you respond, just so we can allow people that might not know or have forgotten or don't pay as close attention to this, the number of people on Medicaid in Kentucky and the problem that we are faced with.
We're in the 30 percentage point, 34, 35 percentage point of our population, and we'll be receiving a significant influx of additional people with the new national health care plan when it comes about. And we have a provider problem, but the concept, I think most people hear about managed care, but the passport concept, which managed care, which is loosely associated with the University of Louisville, what passport does is take Jefferson County, the metropolitan area, and certain other counties that are contiguous to Jefferson County, and the state pays passport a capitated fee, a certain amount per every Medicaid recipient, and in return for that, they provide the services and manage the care of each one of those and keep individual records and make the decisions for referrals. We'll refer them to a particular primary physician, and we'll manage their care, much like if you have a real rough insurance company will do you as far as getting pre-approval for certain things. Whereas, although all Medicaid patients are assigned a particular physician supposedly out in the state. The others are on a fee-for-service basis. So there is some pushback from providers in certain areas of the states. But the main reason, there were other areas of Kentucky that tried managed care, but this system here in Louisville was put together because of the existence previously, and I think you'll agree with this, Greg, you and I being U of L guys, that the University Hospital was the main place that indigent care took place traditionally, the old General Hospital here in Louisville. And so the other hospitals and providers at that time, and the players changed, but you had Norton's and Jewish and the University of Louisville Hospital reached an accord so that they could direct most of the indigent care initially as far as emergency rooms and things to the University of Louisville Hospital Group, and then each one of them shared in the situation, and there were advantages for this system, and the providers came together. Whereas in Lexington or in northern Kentucky and other places, it would be tremendously difficult to put the patchwork of providers together to get a managed care system built. So I agree with the speaker that I think Passport, although you can make a good argument that they didn't save money as far as the average expenditure per person, the greater argument is they provided preventive care and other care that was not provided to the general population and saved money in the delivery of these services because of the kind of care they were able to get in conjunction. So this was a very difficult and heated issue, and we had language that both the House and Senate agreed to. The governor vetoed it and then entered into some pretty tough negotiations with Passport, and they went down to the last day, and people in the general public, I don't think, realized what would have happened, Mr. Speaker, if that contract had not been renewed on the last day. It meant that all of a sudden that system would have not existed, and everyone that was on Medicaid and all those counties would be issued the same credential that any other Medicaid individual would, and they would go out to providers who would have no record, and all the medical records would have had to been dispersed from Passport. It was a dicey situation that we were in, and when you put that together with the other Quality Care Trust and the changes in the federal law as far as the disproportionate share payments that are going to be paid to hospitals who have a high number of Medicaid patients, we're in a tough situation. So we're going to do something about this Medicaid situation. One thing that can be talked about is a statewide management of pharmaceutical needs. We track certain drugs now under the Casper system, but I noticed recently, Mr. Speaker, that an executive order was issued to make them go to more generic drugs as far as over-the-counters. I mean, we can do a better job, and there has been a resistance, an institutional resistance in the state government to apply the management tools that we need to hold down these costs.
Well, some of what you said, and you mentioned the new difference between generics and prescription. What else can be done? And we all know, and we're trying to get our arms around what the new health law will actually mean and what it says, and how, when the savings, if there are any at all, or when the bills will have to be paid. So what else can you tell us that, and you said 30%, in raw numbers, I think that's somewhere in the neighborhood of 750 to 800. 750 to 800,000 people on Medicaid in the state of Kentucky.
And thousands every month signed up.
Will be added. So
let me give you an example. And this was interesting for me to learn, because I had never seen these numbers before. Passport takes a different approach to just the whole concept of providing care. In most places, when the doctor accepts Medicaid patients, he is paid per visit. And so, Denny, if you've ever been to, like it is up home, when you go to the doctor's office and they've got Medicaid patients.
Denny's on Medicaid?
You see, no, but when you go to the doctor, the general practitioners, you can't get in the door because you see the same people there, and they'll bring them back 3 and 4 and 5 times for a common cold, something they treat you and I for, and we'd be back at work because we can't do that. Passport takes a different approach. They pay the provider X amount of dollars, and then they say, if you'll save so much per patient, if you'll keep them from doing, for example, emergency room visits,